In multiple myeloma, we're very fortunate in that not only do we have 2 CAR-T cell products licensed, but we now have 3 bispecific T-cell antibodies licensed, 2 targeting BCMA and 1 targeting GPRC5D. So the challenge is, how do we manage the sequencing of these agents? And one of the things that's becoming apparent is that we need to preserve T-cell function to have the best outcome for our therapies. What's very clear is that BCMA-targeted CAR-T cell therapy is very effective and gives patients a treatment-free interval, compared to the bispecific therapies, which are continuous, and them being continuous leads to the risk of T-cell exhaustion. We also see a significant infection risk with continuous BCMA T-cell antibodies, which you don't see so much with CAR-T cell therapy because you allow immune reconstitution, particularly with the use of IVIG. So in my mind, in terms of sequencing, my preference would be to offer a BCMA-targeted CAR-T cell therapy as early as possible in the treatment pathway for multiple myeloma. Now, if that patient does relapse, and we know, unfortunately, that this modality is not a curable prospect, then a bispecific T-cell antibody is a viable treatment because we are expecting functional T-cells at the time of relapse. What you have to be careful about is, should you retreat the patient with the same antigen, or should you have a class switch? And in my mind, if you are able to give a GPRC5D T-cell antibody such as Talquetamab, that would be my preference following a BCMA CAR-T cell relapse, although I would not rule out a BCMA bispecific. And of course, we should not forget Belantamab mafodotin, which is an antibody-drug conjugate. It works in a very different way, and I think that Belantamab is perfectly usable either pre-CAR-T cell or post-CAR-T cell due to the different mechanism of action.